Hi, everybody. Jeff Ward, Kinesiology 198. And this is Chapter 11, Psychosocial Intervention for Sports Injuries and Illnesses. So, a relatively short chapter, is only 52 slides. However, this is just really the tip of the iceberg. I mean, there's so much information, material on this. So, but really important for athletic trainer, physical therapists, nurses, healthcare providers to understand the importance of the psychosocial aspects of injuries. All right, so the psychological consequences of an injury can be absolutely as debilitating as if the physical aspects of an injury are. When we treat injuries at the clinic that I'm at, we have two problems. We have the knee injury, for example, hypothetically, as well as we have the mental component. So we have to integrate techniques and strategies for both the physical and the mental trauma that are associated with an injury. So going into any kind of a rehabilitative situation or injury management situation, really important to have an understanding of how emotions and feelings enter into the process. Okay, so athletic trainers, physical therapists, etc., they all should have an understanding or an awareness that there are factors that go into the rehab process, culturally, etc., that are going to impact and influence your outcomes, and we have to be sensitive to those issues. All right, so even physically, you're going to have different responses to injuries. Not all ankle sprains react the same way, and but psychologically, not everyone's going to respond a certain way either. There's definitely some common denominator traits that often occur, but not everybody goes through the same process the same way. Just as we just talked about, return to play criteria includes physical components, but there's also psychological healing that has to occur. And I primarily focus a lot on confidence and making sure that individuals are confident in their own physical ability to return. That's a huge component. They go back into it, if they return back to play feeling nervous or anxious, scared, they really run the risk, not necessarily of just exacerbating the injury they're responding from, but hurting something else as well. So, all right, and then the role of personality in injuries must also be taken into consideration. That makes sense. Okay, so just talked about it, but each patient is going to deal with injuries differently, and it can be a very wide continuum of perceptions, where it can be viewed as disastrous or as an opportunity to step up and show courage, etc. Could be used, and I've seen this an awful lot. If I hadn't gotten hurt, we would have won. That I would have played better, but I was hurting. So oftentimes people put that down as an excuse. Looking at in terms of determining severity of injuries, just trying to classify injuries from a psychological standpoint. You're looking at we're looking at classifying short term as less than 4 weeks, long term is greater than 4 weeks, chronic is a recurring injury, and then terminating injury would be a career-ending injury. All right, so here's kind of a paradigm of different types of injuries in terms of severity, length, as well as reactions that are relatively common both to the injury, to the reaction to rehabilitation, and the reaction to return. So basically, you're looking at three different reactions. One is going to be the reaction to injury. One is the reaction to uh, the the strategy that's going to be in place to rehabilitate, as well as the reaction to the return to play. So you can see on that top one, the real short term injuries, things that clear up in 4 weeks or less. The most mild, I guess, of all the injuries that we've got listed here, the reaction is going to be shock, but possibly also relief. Well, it could have been worse type thing. The reaction to rehabilitation is going to be impatience, but also that of optimism, like, okay, well, in 1 week, 2 weeks, 3 weeks, etc., I'll be returning to play. And then when they're return to play, they'll be very eager, anxious, and anticipating their return. If it gets long term, greater than 4 weeks, where there may not be a finish line really all that visible, you'll see how the reaction to the injury changes from fear and anger. And again, not having a relatively tangible finish line, the reaction to rehabilitation can be that of just kind of loss of vigor, loss of pep, irrational thoughts like I'll never be able to do this again, etc. And alienation, very common, unfortunately, a very common consequence of being hurt is that they feel like they've been alienated, and why there's the why is this happening to me, but also there's a separation from the herd, so to speak, and they really feel alone at times. The reaction to return is that of acknowledgement. So they're acknowledging that they're coming back, but not necessarily is it the same as short-term injury where there's that eagerness and anticipation. And certainly these lines are blurred. It's not cut and dry. We talked about that. Everybody responds differently. But when you get into the chronic kind of recurring injuries, it's understandable to see the reaction to injuries, that of anger as well as frustration. So not being able to clean this injury up and get better, it's frustrating. It's frustrating for everybody, including the athletic trainers, the physical therapists. Reaction to rehab can be one of two things: dependence or independence. Dependence meaning they really are going to lean on someone to help them through it, or independence saying, okay, well, I know what I have to do type thing. And apprehension certainly as to, is this going to help or is this going to make it better type thing. There's definitely a lot of anxiety that happens with chronic injuries. And when they are faced with the return to play, they can be either one of confidence or one of skepticism. It's like, well, it's going to happen again type thing. Why is this time going to be any different? And then the final one that we want to talk about is this career-ending injuries. And you're definitely going to run the gamut typically with these, from shock to fear to anger to all of them. But one of the primary things is that they're isolated, that feeling of isolation, and they run through the grief process, and we'll talk about that here in a minute. But that's a very real thing, and especially for those individuals who have a high athletic identity, and we're going to talk more about that as well. But individuals that when they look in the mirror, they see athlete. When you then unfortunately break the news that, okay, well, your career is over, that is a really hard thing to handle. So that reaction to rehabilitation is, well, they've lost my athletic identity, so sometimes what's the use type thing. Reaction to return is, well, there's got to be some closure and possibly some renewal. There may be some, okay, well, I can't do this anymore, but maybe I can do that. So that's really what we want to get into, that kind of component. Career-ending injuries are really challenging. All right, so we just talked about that in the last slide. There's 3 reactive phases are going to occur. and that's going to be the reaction to the injury itself, the reaction to the rehabilitation process, and the reaction to the return to play. And if that's not, if they're not to return to play, then the reaction to the termination, the end of it. Termination of career injuries don't have to be career ending to still have that termination, because they could be season ending and they could be a senior type thing. So, although they still would be able to play basketball, for example, they may not be playing competitive basketball anymore. And so those psychological consequences are still very, very difficult to handle. So I'm sure you guys have seen this as a Kubler-Ross's model of reaction to death and dying. And it's the grief model, the stages that you go through. And again, not all stages have to go in order. Typically they're often, and they're often linked to injury as well. So that's denial, anger, bargaining, depression, and finally acceptance. And typically they run in this order, but I don't think it's that bad. And then they get mad and they say, well, if we just do this, can I play? And then there goes a state of depression, and finally they come up with a plan on how to accept the consequences. Important to note that there may not be that grief process for less significant injuries. They may still run through some of those, but it's not applicable to all injuries. All right, getting into this cognitive appraisal model. This is a model of where the focus is more on the personal and situational factors, and how these influence how they see or how they appraise the injury situation. Okay, so instead of focusing on the actual severity of the injury, they're focusing on how on their interpretation of the injury, and it's sounds maybe semantics, but there's really some value here because, all right, how are we going to handle this versus, okay, what do we have here type thing, and they can be very valuable. And it helps to determine the emotional response and behavioral response. So looking at how the cognitive, emotional, behavioral responses are all kind of intertwined, interdependent, and they collectively influence the recovery outcome. That makes sense. I mean, how you see things and how you're reacting to things and how you then behave are certainly going to have outcomes in the recovery process. So. Okay. Also, other things that need to be considered are coping skills, their social support, personal traits, past history, what's gone on in the past, in terms of how an individual is going to cope with an injury setting, injury situation. And it's important to also recognize that injuries can have an impact on other things socially and personally in an individual's life. And so student athletes, in the college or high school setting, injury, not uncommon to see grades go down, or relationships with significant others to be strained, etc. So really just kind of important to kind of keep that in mind so that you can help with the social support system, and as well as making sure that individual is handling things as best they can. We'll talk about resources that you can point these individuals to in a little bit. Okay, so I talked about in that one slide that alienation and the sociological response to injury. This is really, I think it's quite fascinating actually, because let's say following a long-term injury where there's a long-term rehabilitation process, very common, the athlete may feel alienated from the team, and there's just a lot of sociological um, variables here, and part of it is um, from the injured athlete themselves, and part of it's from the team as a whole. So um, the views of involvement and interaction with other teammates and other coaches and managers, etc., that relationship can be disrupted, and that's what kind of creates that can create that alienation. Um, the relationships between athletes and coaches, the athletes may pull away as injured athletes are a reminder of potential harm, and that's so the healthy athletes here may say, "Oh, and I don't know how conscious of an effort it is. I think it may be a little bit more on the self-conscious thing, but if I and I don't injuries can be contagious, like type thing, and they're not, but there's that reminder, and that I want to keep my athletes want to keep their health clear, and so they may pull back just because there's that reminder that potential for injury is there for everybody. That friendships that are based on athletic identity can be compromised, and it's dangerous. But individuals, teammates where their sole basis for friendship is based on athletic identity. If one of the individuals is hurt and not able to participate, that's a real big blow to their athletic identity. And so friendships that are based on that can be compromised. Um, and so consequently, remaining a part of the team is critical. It is hard. It's hard. There's a little bit of pride that's involved, especially for the individuals that are good starters, for example. Players that are the big fish, so to speak. When they're hurt, they how do they remain part of the team? What can their role be? Whether it be passing water bottles out at practice or keeping stats with a clipboard and pen, um, or kind of just cheering from the sidelines. That can be a blow to individuals' egos and can be a little bit difficult. However, by trying to integrate that individual into the team, you get less isolation and guilt. So it's really important, but it's not that easy. All right, so getting that injured athlete, the social support that he or she needs, and there's different avenues to go about doing that. Like in the training rooms is a really good place because injuries happen and people are in there, and the nice thing is they're not all the same team, generally speaking. You've got individuals from different sports, and that little support network within the training room clinic is actually quite beneficial, and focuses on trying to prevent that feeling of negative self-worth or loss of identity. Um, I'm saying that the remaining a good teammate is important. As there's value there. We talked about that in that last slide. Support for the between the athlete and the athletic trainer, or the physical therapist, chiropractor, the healthcare provider for the athlete. That's really important, and it's one of the things that it's one of the things that I most enjoy about my job is the relationships that I get to develop with our athletes, and it's critical because you become definitely a mentor to these individuals, but you're definitely also an ear for them to talk to, a shoulder for them to kind of lean on a little bit. So it's really the relationships, like anything, have to be developed, and ideally you're working on those relationships before the injury happens to begin with. But certainly friendships are forged after the injury happens as well. Relationships there. And then when you're incorporating, when you're getting an athlete back into sport-specific rehab drills, it's really important, I think, to make sure that you're doing them uh, in front of the team. So, you may not be involved in the team drills, but if you're on the sideline doing agility drills, so not only the injured athlete sees his teams practicing, but his team also sees the injured athlete working out, trying to get back. It really does create a nice re-entry into the team process. Uh, there's definitely, because people can see you working out, you'll get an increase in motivation and effort oftentimes, and you'll and it's really reciprocal. The team can see how hard the injured athlete is working, and the injured athlete can recognize, okay, what I need to be able to do to get back to be part of the program. So that's a really good thing. Ideally, you do that during practice. Ideally, you do that um, when you have team drills. And the nice thing is, as that progresses, then you can insert them into team drills as appropriate. So if there's a non-contact drill, okay, once you jump in this drill, okay, pull back out and let's do some more stuff type of thing. Okay, so athletic trainer's role in providing social support. Again, we talked about how important the athletic trainer is, the physical therapist is, in the role of getting individuals back to return to activities. Um, it's a huge impact, I think. Communication's super important, um, and we talked about that in a couple slide or two ago about how you really want to get invested in your athletes prior to an injury occurring. That way, you've got a little head start on the relationship. There's a kind of a list here of what athletic trainers should be doing. Um, Certainly a good listener. You're gonna, as athletic trainer, I consider the athletic training room kind of a sanctuary. They can complain all they want about the coach or about this professor, that professor, about boyfriend, girlfriend, etc. So just being able to have it be a sounding board for some athletes to kind of vent and vet, it's really kind of helpful. But athletic trainers should need to be able to find out what the problem is. And it's not just physical problems. You have to be able to get to the mental problems, the emotional issues as well. Body language is really important. I mean, certainly we look at body language in our evaluations, in our observation, how are they holding their posture, etc. But recognizing if they're having a bad day type thing and they may not say it, they may not want to say it, but based on body language, you can pull some information out. Typically, most athletic trainers already do that, but physical therapists, etc., you don't do this profession for, um, not necessarily do it for the money. You're doing it because you want to help people, so projecting a caring image. I like this next one. Explain the injury to the patient. I am big on trying to over explain things. I try to really get ownership of the injury. I really try to spell things out for the athlete because this is it's theirs. The injury is theirs. It's not ours. It's theirs, and they really need to own it. Um, and I'll do the best I can to help them, but really want to make sure that people recognize, my athletes recognize, okay, what's going on, this is what we're going to do, and that I'm there to facilitate the process. So we're a team, but they've got to really own the problem. So and they need to be able to manage the stress. This is, if I were to do it all over again from my education, I would have got my bachelor's degree in athletic training. I think I would have gotten my master's degree in sports psychology because I think the connection between the emotional and mental with the physical is just so important to be able to handle that. I think we get a lot of people back better, quicker, when you've got a healthy mind and healthy emotions when you're dealing with a physical injury. Obviously, that's what last one is why we're here, is to help the athlete return to competition. All right, so predictors. Can we predict psychological traits? Are there psychological traits that may predispose athletes to injuries? And while there's no one specific personality type, there is some predictors of those that are risk takers. But then that could be individuals that are apprehensive or overprotective or easily distracted. So definitely a risk taker that's apprehensive and overprotected is you're kind of creating a case here. And so a lot of athletes kind of play sports because they like the thrill of the adrenaline, et cetera. So they are risk takers. If you return them to sport too soon, where there's apprehension or they're a little protective of the body part that they just recently injured, you may are set the table for less than optimal situation. Individuals who lack ability to cope or stress with associated risks certainly are predisposed to injury. And this is interesting. Other potential contributors include attempting to reduce anxiety by being more aggressive. So if they're anxious about maybe a performance anxiety, they say, well, I'm just going to try harder. Then you get kind of, I had a rugby coach who once described this individual we had, and he was like he described him as a race car driver without a steering wheel. The car would go super fast, but this guy had no control over it. And so really aggressive, but not real refined in his movement patterns. And consequently, he got hurt quite a bit. We had to try to tone down his aggressiveness, which generally speaking in sport is considered a positive attribute, but he didn't have real refined coordination of that aggression. And so he put himself in a lot of harm's way. All right, so stress and the risk of injury. Stress, what is it? It's positive and negative forces that can disrupt the body's equilibrium. Stress tells our body how to react. So, not surprising, but there's been a number of studies out there that have indicated that injuries, particularly in high-intensity sports, can have a negative impact of stress. Well, that makes sense. You get hurt, there's a negative impact of stress on the body, which can result in decreased attentional focus, creates muscle tension, resulting in reduced flexibility, coordination. So you see now we're getting from a stress, which is a mental, emotional situation, causing physical consequences that certainly would impede in the recovery. Different types of stress, eustress and distress. Eustress is the positive stuff, that's the good stress, positive stress. Distress, negative, we know what distress is. Now there's slight differences. They're actually very similar, but there are some differences. So good news is living organisms have the ability to cope with this stress and without it. So that's why stress is actually important on the body. Without stress, there'd be little constructive or positive activity. And just recognizing that there is countless stressful situations that you deal with daily, and that's how we respond to life, I guess, so to speak. Fight or flight, we've heard that term, or freeze, I guess, is the third component there. But those occur in reaction to avoiding injuries or other physical or emotional threatening situations. So the physical response to stress, as we just kind of talked about a little bit, I'll reiterate here, but that's that psychosomatic phenomenon where there's an actual hormonal response results in a cortisol release, so which can cause fear and anxiety, which helps stimulate that fight or flight response. Adrenaline, physically, adrenaline can impact or influence the pupil dilation. Your hearing becomes more acute. Muscle responsiveness increases. Blood pressure, heart rate, and respiration can all increase. So all physical components to this hormonal response. All right, so we just talked about eustress and distress as two types. This bullet here is talking about acute and chronic, whereas the acute is the now, the threat's immediate, and the response then is instantaneous. So that typically involves the release of epinephrine and norepinephrine. The chronic is the long-term stress and really unhealthy. That leads to an increase in blood corticoids. There's negative physical consequences of that, but the corticoids from the adrenal cortex. Just focusing on, when an athlete is taken away from a stress standpoint, it can just be devastating, really difficult to, it could have a significant impact rather on attaining goals. All right, so just a slide of this girl watching soccer practice. Probably one of the more lonely places to be is standing on the sideline watching your teammates do what they do. All right, emotional response to stress. The sport does serve as a stressor, performance, anxiety, etc. But there's also expectations of others. There's concerns about school, family, work, etc. Having a coach is great. Oftentimes they're the first to notice if an athlete is emotionally stressed out. So, and that's due to changes in personality and performance, and that may be the indicator that puts up the red flag. Say, maybe we need to change some things in either the training program, conditioning program, etc. Conference may reveal a need for additional support staff to become involved, and you're starting to see this growing. That sports psychology in the collegiate setting is definitely growing, so which is a good thing. All right, so injury prevention is both psychological and physiological. So this is for someone that's healthy, but not yet injured. But when individuals enter an event in an emotional state where they may be angry, frustrated, etc., discouraged, that may actually increase that individual's risk to injury. So due to emotion, skill and coordination can be sacrificed, can be compromised, and potentially they are a little bit more at a predisposition for injury. So athletic trainers, a huge component of what we do is that of a counselor. We talked about that. A lot of times people just come in and it's just an opportunity for people to kind of vent, etc. But there's a lot of counseling that we can participate in, and there should be some skills in dealing with that. So better training associated with that. All right, so talk about overtraining here just a little bit. The overtraining is there's an imbalance between physical load and how they can cope with that. So when they train too much and they can't recover emotionally, physically, etc., then they run into this risk of overtraining. Can lead to staleness, which we'll talk about, and certainly can lead to burnout, which are physical components as well. So staleness is, just as you can kind of imagine, it's not fresh, and there's numerous reasons that are included, but the primary one is that training is too long and too hard
and without the proper amount of rest. So it doesn't have to be a single event. It could be just a season, or even a career process where they're practicing or playing 6 days a week for year long, where there's very little chance to just kind of decompress and recover. One of the risks and one of the fears that I guess I have is where we're getting individuals playing one sport year round at a younger age. You got 6, 7, 8 year olds playing soccer year round, and they're not getting that cross training or that decompression time. So it's not having a 3-hour workout with very little water breaks. It can be training for 4 months without having too many days off type thing. Um, there can be attributed to emotional problems stemming from daily worries and fears, etc. Anxiety it can be nondescript fear, so it's this sense of apprehension. They may not be able to explain why, and it can turn into some physical symptoms such as heart palpitations, shortness of breath, just headaches, constriction of throat, etc. Oftentimes seen minimal positive reinforcement, so can create that an athlete to staleness, and so just very very little positive feedback. Okay, so some of the symptoms: performance goes down, blood pressure and pulse rate at rest can go up, and resting heart rate. You take during the morning when you first get up, and that's when it should be at its lowest, basically, because you've been sleeping. And if that elevates, that is could be indicative of increased catecholamine release, and that's a sign of that adrenal cortex stress. So when that happens, then you could take some time off type thing. Stale athletes can become irritable, restless, frustrated. They don't know why their performance is going down. They don't know why they're having these issues type thing potentially. Certainly, you're at an increased risk for overuse injuries. And prevention is probably the best, but recognition and early intervention is going to be critical to this, for this to work. And then taking time off if you can recognize it early enough. So burnout is a consequence. I mean, if things continue going, if things continue, then they can turn into this burnout, and this is related to physical and emotional just exhaustion. They're just done, where there's a negative conception, negative when they see things as negative of themselves, their job, their sports attributes. They just don't care, and loss of concern for feelings of others. So this stems from overwork, and can have effect on both the athlete and the athletic trainer. Interesting, we're talking about athletes, but athletic trainers have a very high burnout rate. So, and we talked about that, I think, in one of the first couple chapters, but just due to the long hours and the constantly trying the pressures of getting people better, burnout's pretty high in athletic trainers as well. But certainly can impact your health with stomach issues, insomnia, sleeping, chronic fatigue, headaches, and then that just emotional fatigue. So as I talked about before, I think if I were to do it again, I would have. I really liked athletic training program, but in my graduate program that I went to in graduate school, I did take one sports psychology class, and I really wished I'd have focused on sports psychology in my graduate studies, because athletic trainers are not usually trained in areas of counseling, and you may take one or two. I took a couple psych classes undergrad. I took the one class in graduate school, and I did some independent research in sports psychology as well. But That's not enough, I don't think. I think it could be better, I guess is what I'm saying. Um, so, you know, not just focusing on the injury, but focusing on the person is really important. And I like this term, emotional first aid is required. And so you're not just treating the body part, you're treating the person as well. And recognizing, okay, this is all normal to an injury response, and letting that individual know that, I think it's really, it really helps. And it definitely solidifies and strengthens relationships. Certainly if an injured athlete recognizes that there's people that are on their side, it's appreciated, and it's a great part of the job, actually. And then part of the athletic trainer's responsibility as a member of the sports medicine team is they need to be prepared to answer questions or concerns. And if they don't have the answers, that's okay. Just go and search them out. And oftentimes with the athlete, it really helps. Okay, catastrophic injuries. This is injuries that result in permanent functional disability. Certainly, the psychological impact of the trauma is going to be critical, and the ability for the athlete to cope is going to be profound. This is going to these catastrophic injuries will profoundly affect all aspects of a person's life moving forward. So, and it can also have significant effects on the people around them. And so that's really important. This is where you may consider bringing in some psychological counseling, some professional help, not just for the person that got hurt, but for the teammates, etc., as well as maybe even just athletes in the department, because this can have a significant effect on individuals. And to say that the athletic trainer is immune from these effects is it's not true. Athletic trainers may very well be emotionally affected. I think one of the reasons why I think burnout is so high in athletic training is because of the day-to-day emotional stresses that athletic trainers have to deal with. You're dealing with injuries and the pressure of getting individuals back, the pressure that is placed on the athletic trainer from the athlete, the pressure that's placed on the athletic trainer from the coaching staff, etc. Because day to day, every day, we make decisions regarding the care and management based on the training, and so it's a lot. But the emotional attachment, because you grow to develop these relationships, you really can't allow that emotions to cloud your judgment. And again, we talked about outside counseling can be really good to help with coping. All right, so psychological factors. So whenever you're putting together a rehab program for an injury, you have to take into consideration the psychological components. And again, that's one of the reasons why education, athlete education, is so important, in my opinion, is that you are informing, you're educating the athlete on what is wrong with him or her, and so you can develop this rapport and this team kind of cooperation, how we're going to do this together. Definitely based on trust, that the athlete recognizes that you're trying to help them, and that's really important. But trust goes both ways. The athletic trainer has to trust that the athlete's going to do their part, so very important. So cooperation, talk about kind of some of the things that happen. Definitely athletes, if things aren't moving in a fast enough pattern, athletes can start to become a little disgruntled in with the rehab program, and they may place blame on the sports medicine staff. To avoid those, ideally you develop that conversation where it's two-way conversation, and you can talk through most of these problems, but recognizing that you can't necessarily rush. We talked about this in the healing response. You can't rush physiology, but it's a process. We're just trying to facilitate the healing response. And again, it has to be communication has to be is absolutely critical to putting this stuff, putting it down before it gets to be a big deal. Okay. All right. Just an ankle, looking at looks like an inversion maybe, pointing at those anterior talofibular ligaments, which you guys all know about now. It's ankle injury. I don't know why he has his shirt off, but whatever. Okay, so psychological approaches during the different phases of rehab. So immediately, there's just the fear and the denial reign, and this is where there's just an unknown. What's going to happen? How am I going to? What's going to go on? Type thing. So there's a bunch of mental questions going on in an individual's head. They don't know what the true consequences of the injury are. They don't know how significant the injury may or may not be, etc. But they also might be in pain, right? So we talk about this when we do our special tests. They may actually physically be hurting as well as have this mental trauma that's going on. So really have to kind of try to sit down and try to slow down everything and go through things systematically. Again, that emotional first aid must be administered, really trying to get them to calm down and let's take things one thing at a time type thing. I really like a complete diagnosis and explanation as best you can, right? So you don't have all the answers right away because you may need to do some diagnostic tests. Well, it may be this is why we're going to do that. So really spelling out the process and explaining potential outcomes I actually like to do as well. I don't like to sugarcoat things, but you don't want to be so callous and terse where you're just saying, okay, this is what it is. So you kind of want to kind of play the midline there, but really trying to explain what the whole process is and what we're going to do. What's our next step? And if they have questions, then you do your best to answer them. All right, so early post-op period. So I like before they're even out of the operation, before they even go into surgery. Let's go through this. Making sure that you're setting them up for what the process is going to be. Getting to the surgical center or the hospital, etc. Really walking them through so there's really little surprise or just not knowing. The fear of the unknown is really challenging. So just spell things out as best you can. And then recognize what you're going to feel post-operatively. So must maintain aerobic conditioning if it's possible. I mean, it depends on the surgery type thing, but if you can, you want to get them doing something early as you can. Advanced post-op and rehab periods, so doing conditioning to train the body parts that aren't affected. So if it's a leg injury, you can do upper body stuff, that kind of a thing. But gradually focusing on building that confidence, and again, patient must feel in control. Well, the only way the patient's going to feel in control is if that individual is informed, educated, and prepped. So they're not going to feel in control if they don't know what's going on. Positive reinforcement's critical milestones must remain realistic. So I like what I call is celebrate the victories. So If you say, okay, well, in 6 months from now you'll be returning to your sport, that's an awful long time, and but if we say, okay, let's, in 1 week our goal is this, in 1 week our goal is this. So break the goals down into obtainable, difficult to attain, but attainable measurements, and attack those and enjoy the small victories. That will boost their confidence so that, down the road there's less of a mental therapy that needs to be done. And then certainly transitioning into sport-specific exercises, ideally with their teammates during practice. All right, return to play. Oftentimes they'll be physically ready, but psychologically there'll be a little bit of anxiety, and just to clear this up, I mean, you're not gonna, typically athletes don't return 100% pain free. They may still have a little bit of pain, but they're functional and they're strong and their range of motion's blah blah blah. But so they're not going to be 100%. Typically, they're not going to be 100% anxiety or maybe a little lack of confidence. There may be a little bit of that. So that's the nice thing, is you're not necessarily going to throw them into a game situation, but you may throw them into some drills enough to the point where they are able to gain that confidence back. And with our ACLs, for example, ultimately what they need to do is they need to be able to fall, to take a hit type thing, and then be able to get back up. And that's really how you're going to establish that confidence. You're really not going to get that confidence back until you're able to get over those hurdles. So again, in order to regain that confidence, has to be small victories, and going from sport-specific skills to small group practices. Practice versus games. The practice running through those drills is just definitely more organized. In a game, you're not going to, you're not necessarily going to know your opponent. Practice, you certainly know your teammates, and you're not going to be able to just step out of the drill, put your hand up, and say, I'm out. So in a practice, you certainly can do that. And then the systemic desensitization is focusing on relaxation techniques, anxiety identification, doing some things that can kind of break down that anxiety. Really good stuff. Okay, goal setting. Super important. You have to have goals, short-term goals and long-term goals, and and you have to make sure that they can't be the athletic trainer goals. They have to be the athlete and the athletic trainer goals. Got to agree to those. Okay, so in order to enhance goal attainment, what you want to do is really kind of integrate the following. That obviously positive reinforcement is really important. Have a strategy. Have a strategy for incorporating the goals into the lifestyle. Making sure that the athlete, the patient, has that social support, and again those feeling of self-efficacy. So having some ownership of the process, I think, is really important. I like to set goals. Daily goals, I like to have treatment goals. Okay, by the end of the day, we want to increase range of motion 10 degrees. We have some treatment goals, weekly goals, monthly, yearly, etc. But again, you want to make sure that they're short enough that they're attainable and that you can celebrate regularly the victories. Okay, so mental training techniques, definitely been around for a while, certainly at the professional Olympic, and now getting much more mainstream in the collegiate environment. I think you're going to start to see it even work down a little bit lower, down into the high school and even club and rec leagues. for enhancing performance, and it's certainly useful during rehabilitation. Certainly, when you get more into the emotional disabilities, that's needs to go to a professional. But there are certainly a bunch of things that are available to help cope with with the response to injury. So in these techniques we're talking about for reducing tension, anxiety, goal setting, etc., like that, as well as imagery, etc. So we'll talk a little bit about reducing tension and anxiety. Again, we talk about how the stress of anxiety can have some physical consequences with tension, etc. So meditation is something that certainly can be done to help with reducing both anxiety and tension. Progressive relaxation is where there's muscle contractions followed by relaxation, really effective. Yeah, cognitive restructuring, I think this is wonderful. This engagement in irrational thinking and negative self-talk, and everyone has this self-talk, and whether it's positive or negative self-talk, it's that voice inside your head that tells you can't do this, you can't do that, you can do this, you can't do that. That negative self-talk is that voice is louder in some people than it is in others, and it can certainly hinder the process, because people will say I can't do that, and they'll just shut down. That voice is too loud. I'm not going to do it. They won't try. So it's irrational. But there's a couple of strategies. One is this refuting irrational thoughts, and that's that internal dialogue, dealing with that internal dialogue. So this thought stopping is where actually telling yourself, nope, stop. I'm recognizing that I'm having a negative self-thought, that I'm going to tell myself to stop, and then you immediately replace it with a positive statement. And again, sometimes it sounds very semantics, but it's surprisingly effective. We're just programmed to accept that negativity, and if we just can consciously recognize that no, we're filling ourselves with negative thoughts, that to say stop, I'm going to change it to positive, it can have some surprisingly good consequences. Now, we talked a little bit about imagery, and this is where visual images are used in the rehab process, and you can go through rehearsal of an exercise or a drill, and then that will then transfer to potentially to motor skills. So so first of all, coping rehearsal, and you can visualize the problem and a way to overcome it and become successful, versus mastery rehearsal, which is visualize successful return from practice to competitive activities. So basically you're putting a positive image in your head, you're walking through the whatever the sequence of events is that you're trying to do, and you're concentrating on that. Very effective. There's the emotive rehearsal, and that's in gaining confidence by visualizing scenes relative to confidence, enthusiasm, pride, etc. And body rehearsal, actually visualizing the body healing itself. So again, in order for that body rehearsal to work, the athlete needs to understand what the injury is. That's again goes back to the healthcare athlete provider, the patient athlete provider, where education is really important. Okay, different techniques for coping with pain. A couple of simple techniques that can help. You're not going to get rid of all the pain just because pain is a protective mechanism, but there's a few things here that we can talk about that can help reduce some of that pain, and they include this tension reduction, attention diversion, or altering pain sensation. So first one, we'll talk about tension reduction. That's work to reduce muscle tension. Okay, so that pain spasm cycle, pain causes spasm, spasm causes pain. That just snowballs, right? So in terms of trying to focus on reducing muscle tension, will reduce pain. Increased tension, increased pain. Reduced tension, reduced pain. So that's one. That's tension reduction. A tension diversion is getting your attention away from the pain of the injury. So doing something else. For me, when I, for example, like if I'm running and if I go for a long run, I'm getting really broken. I'm starting to hurt a little bit. I'll do math questions in my head. Sounds kind of nerdy, but it gets my mind off of the fatigue I'm having when I'm running. So it seems to work for me. But you could also divert pain by just kind of daydreaming about something that's more pleasurable. So that's a tension diversion. Kind of name gives it away there. And the last one here that we'll talk about is altering the pain sensation. And this here is just utilizing the power of your imagination to try to alter the pain sensation. Okay, so mental disorders, again, this now is starting to get a little outside the scope of athletic training, but occasionally athletic trainers will run into athletes that do have mental illness and possibly undiagnosed mental illness. And so you want to be able to recognize when an individual is having problems and be able to make the appropriate referrals. And the referrals would be to, in college setting, might be to your student health center, maybe your team physician, maybe to the athlete's primary care physician, etc. But mental illness is basically defined as any disorder that affects the mind or behavior. Okay, so a couple of classifications: neurosis or psychosis. Neurosis is an unpleasant mental symptom in an individual with intact reality testing. These symptoms include anxiousness, depression, or obsession with a solid base of reality. Psychosis, on the other hand, is a disturbance in which there is a disintegration in personality and loss of contact with reality. Neurosis, a solid base of reality. Psychosis, we're losing contact with reality. And psychosis typically characterized oftentimes by delusions or hallucinations. Okay, so mood disorders can range certainly from happiness to sadness. It becomes pathological when it disrupts normal behavior, right? So if it becomes now dysfunctional is when it becomes pathological. And it can be prolonged and accompanied by physical symptoms, so i.e. can't eat, can't sleep, etc. Depression, very common, oftentimes undiagnosed as well, but we got unipolar, and that's feeling from normal to helplessness, loss of energy, excessive guilt, not able to think or process. Oftentimes eating and sleeping habits are disrupted. Bipolar goes from that's really a big pendulum shift. Exaggerated feelings of happiness and great energy to extreme states of depression. So treatment is going to be individualized, just like a lot of the things that we've been talking about, and can include medication or therapy. Okay, and then talk about the seasonal affective disorder. We don't see it too much here in California, but up in the Northwest, it's a little bit more common, I think. It's that mental depression during certain points of the year due to the decreased sunlight. And they call it seasonal affective disorder, SAD. More common in women, and it's treated oftentimes with light therapy, stress management, antidepressants, as well as exercise. Okay, so anxiety disorder contributes to 20% of all medical conditions, and it can cause a variety of physiological responses. So, really, it's a big player. Anxiety is, and abnormal when it begins to interfere with emotional well-being. So, again, it's considered pathological when it starts to create some dysfunction. So. Panic attacks are unexpected, unprovoked, emotional. These are intense experiences of terror and fear, and they are similar to someone that would be fearing for their life. So they're very real and very scary actually. They tend to occur at nighttime, more dominant in the evening, nighttime, and they tend to run in families. So. Behavior modifications and relaxation techniques, as well as medicines, can help with treatment. Okay, phobias. They're irrational fears, persistent irrational fears of a specific situation, activity, or object. And oftentimes many of them involve social situations. Could be fear of heights, fear of closed spaces, fear of flying, etc. And they can translate into some physical symptoms such as increased heart rate, sweating, dizziness, difficulty breathing. And again, treatments include behavior modification, maybe some antidepressants, and the systematic desensitization. So exposing the individual systematically to their fears to help them overcome them. All right, personality disorders, pathological when there's a disturbance in cognition, interpersonal functioning, impulse control. Generally, these are long-term duration, traceable to some event, and treatment can involve some therapy medications. Paranoia, unrealistic or unfounded suspicions. Basically puts an individual on constant guard, and they can be, it's irrational, they can't be convinced that their suspicions are incorrect. Over time, these can result in require medical care. And obsessive compulsive disorder, OCD. This is emotional and behavioral symptoms where there's just inappropriate thoughts, feelings from within, and it can't be neutralized even though they can be known to be wrong. Okay, so these individuals with this disorder tend to engage in unreasonably repetitive acts, so washing their hands repetitively, locking the door repetitively, and it certainly can have a disruption in their normal daily functioning. Therapy, behavioral psychotherapy attempts to restructure their environment, minimize the tendencies that compulsively have shown to help, as well as some medications can be used as well. Okay, so the last one here is PTSD, or post-traumatic stress disorder. We're definitely getting much more familiar with this recently with the military and what have you, but it certainly is not isolated to the military. It's a disorder that's caused by individuals that re-experience a psychologically traumatic event. So that could be a sports injury, or it could be something that's happened in their childhood, etc. So may experience numbing, general responsiveness, just kind of loss of engagement type thing. Insomnia certainly is a common one, as well as it can be increased aggression rather. And this can last, unfortunately, for years, decades, if not treated, and can last a long, long time, unfortunately. Group therapy tends to be useful for treatment in this case. So, okay, well, that wraps up the sports psychology chapter. If you guys have any questions, give me a holler. Otherwise, I'll talk to you soon. Bye-bye.